off a minute. Put your thumb up when you're ready. Good evening, everybody, and welcome to Herts Essex Open Evening. I hope that whereabouts you are on your journey, that tonight's insights will give you a little bit more about what Herts Essex can offer you and whether we can be helpful or resourceful on your journey. So tonight I'm going to give you a presentation so you get a little bit of a feel of what Herts Essex can offer you. At the end of the presentation, it's sad that we're not able to have you here in the clinic with us, but it means that we can have more of you have access to us. So at the end, I'll show a video that will give you a virtual tour of what the clinic looks like so that you can hopefully start to get a bit of a general feel. There are questions and answers that you can ask throughout the presentation. Joining me tonight, I've got Marna Marks, our marketing manager, and Jackie McAdam, who's one of our senior fertility nurses. So they're able to answer questions throughout the presentation, but we will stay live at the end of the evening. So it gives you opportunity if there's burning questions that you need to ask. It's really important that you give us feedback. A big thing at the moment is the timing of this presentation. So we've tried it at all sorts of different times. So it'd be really interesting if you could give us a little bit of feedback on whether it's too early at 6 p.m. or whether it should be later at 7. Perhaps give us a little bit of feedback. That'd be really helpful. I'm Debbie Evans. I'm the Director of Clinical Services at Herts Essex, and hopefully by the end of the evening you'll have a little bit more information so that we can support you on your fertility journey. So just a little bit of history about Herts Essex. We were founded as the Essex Fertility Centre back in 1989. So do the maths, and that counts up to 34 years of relevant fertility experience. We're not a gynecology unit, we're a purely fertility centre. We've delivered over 7,000 babies and lots more coming in months to come. Everything, all the procedures that you'll need throughout your journey on your fertility pathway can be performed under one roof. When you come and visit the clinic, you'll see that we are a state-of-the-art, purpose-built clinic that meets the needs and the requirements of our regulatory bodies, but also you as our patients. So what can we offer you at Herts Essex? So we need to start somewhere. We need to think about fertility assessment right through to the more complicated treatments that we can offer you. And I'll go through some of those throughout the presentation. So as you can see, a whole array of services right from the beginning, right through until the more complicated procedures. So I'm going to start this first slide with a donation side. Some of you sitting in the audience tonight might already know that you might need egg donation or sperm donation, or you could be that you're in an investigative stage and we take you on that journey with us. So why would you need egg donation? It could be your age and that your stock of eggs has run out, that you've hit the menopause early, and so therefore that your chances with using your own eggs would be quite diminished. It could be that you've had chemotherapy as a result of cancer treatments, and it's meant that your ovaries are no longer viable to produce eggs for us. It could be that you've had treatment and your egg quality is diminished, it's quite poor, and it's not able to create an embryo for you. Could be that you know that you've been born without ovaries and that you might actually need surrogacy, and egg donation might be part of that too. With the guys, it could be that you know already that you aren't able to produce sperm, and so you would need sperm donation. Again, for the guys, it could be that you've had chemotherapy which has damaged your sperm production, and therefore you need to think about a sperm donor. It could be for various genetic disorders that do affect sperm parameters, and you might think about, rather than causing that genetic link, that you use donated sperm. And then, of course, if you're a single lady or in a same-sex female couple, you are going to need the use of a sperm donor. So all of that is available at Herts Essex, and if you're particularly interested in either of those pathways, then do feel free to message in and talk to us. So we need to start somewhere. We need to understand, have we got eggs and have we got sperm, wherever they're going to come from, whether they're your own gametes or you need to use donation. So we do a fertility MOT. So that's an assessment that's carried out over 2 visits over a 2-week period. Predominantly we're looking at, in females, we're looking at your egg reserve. And that's tested very simply by a simple blood test called anti-Müllerian hormone. and I'll talk through a little bit over the coming slides over that, and an antral follicle count. So we want to match what your ovarian reserve is telling us through your blood, that what we can see in your ovaries is matching. We also do a 3D, a very detailed scan of your uterus and tubes if we're going to use IUI procedure. So we want to make sure that we've got eggs, we've got sperm, and we've got a receptacle, so a uterus that's fit for purpose. With the guys, we do a very detailed semen analysis. So we drill down into your sperm parameters to not only know have we got a high enough volume of sperm, but is that sperm functioning in the best way that it should be? And then we also do a female mini fertility assessment. So that just involves just your AMH and that antral follicle count. So all of those will give rise to us having a diagnosis at the end of it that perhaps we can fix, that we can support you through a fertility type. So it's really important that you find out exactly where your status is. Have you got eggs and have you got sperm, and can they create an embryo? So I just alluded to the anti-Müllerian hormone. So that's the test that looks at our ovarian reserve. So as girls, we are born with our stock of eggs. And by the time we hit puberty, we have around about 250,000 potential eggs, which are born out as antral follicles. If you look at this slide here on the left-hand side, that's an ovary. And around the circumference of that ovary, you can see these tiny little black dots, which are the antral follicles. So they are the sacs that hopefully contains the egg. So when we're measuring and we get a normal or high level of AMH, we're going to see this under a microscope. So you can see there's red and green dots. The green dots are the really good quality, likely to create embryos. And then we have the red dots that are the troubled eggs that are not very likely to give rise to pregnancies. And then as you get towards the age of around about 35, our ovarian reserves really starts to diminish, and we are losing those good quality, able to create embryo eggs. So if you see the slide on the right hand side, an ovary that's, instead of having all of these follicles around the perimeter, it's got one or two. So the chances of success are much lower when you've got a lower level of AMH. And as you can see when we look under the slide, that we're going to see a much lower proportion of genetically normal eggs. So the green dots are diminishing, they're disappearing. And what we're left with are eggs that are not likely to give rise to pregnancies. So it's really important, and it's a very quick indicative test that gives you a very secure answer on whether you've got ovarian reserve and what that quality of those are going to be. So once we've had assessments and we know that we've got eggs and we've got sperm, but you're not getting pregnant, then you need to come to the fertility clinic. So you come via us through a consultation. You can refer yourself, or you can be referred via your GP or consultant that you've seen in the gynecology clinic or other clinics. So it's a two-part consultation. You register with the clinic and we will send you details about our fertility online consents platform. There are several things that you'll need to complete prior to attending the consultation. We'll talk you through all of those forms. We give you separate logins so that both partners have an individual login and you both complete the forms at the same time. You will have to give us a copy of your passport, and you can upload that yourselves through the online platform, and that ensures that we're treating the right people. If you've had any relevant investigations, you've had tests done in your NHS or in other private clinics, then get copies of them, because it may prevent you having to have those repeated. So it's always wise to get a copy of those. Then once you've completed all those forms, you attend the clinic in person, and that's for a pre-assessment. We need both of you in the relationship to attend. We'll do observations, so we take your routine blood pressure, temperature, etc. And we will do those blood tests if you haven't had them done already for the AMH test, but it will also do the thyroid function, because thyroid is very indicative of fertility measures. So you need to make sure that you've got a good functioning thyroid for you to go through fertility treatment. So that's for the female. We'll do your BMI for both of you. If you're in a heterosexual or same-sex couple, it both applies, and it needs to be below 34 if you're going to be the female that's having the eggs collected under sedation. If there's a male partner, then we will give you a pot that you'll take home to produce your sample. We'll give you very clear instructions about abstinence periods, how you need to produce the sample, and give you a date on which you return that sample so it can be assessed through the laboratory. So once we have the female and the male tests carried out and we've got those results, then your consultation will be booked, and it's generally around about 2 weeks after you've initially booked in. At the minute, our waiting time for consultations is 4 to 6 weeks. That consultation will be via Microsoft Teams in the same way that we're doing tonight, but you will meet with your consultant. That consultant will have to identify you both, and that's where your passports come in so that he can or she can make sure that they've got the right people sitting in front of them. So we send you that invitation on the day of the appointment. We do ask that you treat this as respectfully as if you were coming into a clinic or a hospital appointment, that you create a safe environment for you to sit and have that consultation at. So don't have one of you sitting in the car and one working in your office, because it's physically just not going to work. Having distractions, it's an important first consultation, so commit that time to it. It's approximately an hour. We need for you to sit together so that you're in a quiet space without distractions, so that you can concentrate on what the consultant has to say. So once you're in the clinic system, we have an app which we're very proud to partner with. We were the clinic that helped develop this app to just make the life easier for you. So it's a much better way of us being able to communicate with you safely and securely. So we ask that both of you in a partnership have your separate logins so that you can both keep an eye on what's going on. So the salve will monitor your medication. It will manage the drugs that you're taking. It will give you information about those drugs and any side effects that you might be experiencing. So rather than being stressed or worried, you can quickly look up what's the side effects. Is this okay? We monitor your appointments through the app. We make sure that all your appointments will be on there, so it's connected to your phone and your calendar. There's extra information on there, so if you're sitting worrying about at home, then you can access that information fairly easily. It's the best way of communicating with us. You know, if you're sitting in the middle of your office and you can't pick up the phone to talk to us, you can message us. And I have a nurse sitting on the phone system that comes through directly, but she's also answering any salve messages. So it's a really clear, easy way to communicate with us. So as you're all sitting there this evening thinking about embarking on your fertility journey, I just ask you to really consider thinking about being in your fittest place for fertility. So if you log in here onto our sister website here, there's lots of information about how you get yourself fit for fertility. There's no quirky sets of drugs or anything that you need to take. It's just about good nutrition, good exercise, well-balanced meals, drinking plenty of water, getting yourself into the best physical and mental health that you possibly can. It's really important that you really commit to this. And for guys, when you think about producing your sample of sperm, what you did 3 months ago will affect the sample that you produce today. So it's really important that when you're thinking about embarking on this journey, that you really get yourself into the best physical state. So the next step, once we've decided that, yes, you do need a fertility treatment, then you'll meet with one of our experienced fertility nurses. And again, that's via Microsoft Teams, and it's called the TIA, the Treatment Information Appointment. Both of you need to attend because we're going to be giving you consent forms that you need to sign and understand together, because when we're creating an embryo and we've got a couple sitting in front of us, we need to make sure that you all know where those gametes are coming from, where the eggs and the sperm are coming from, and where the embryo is going to be created. We'll talk to you about administering your daily injections, and we'll demonstrate that when you next come into the clinic. Excuse me, lots of talking today. We'll also at that appointment make sure that you understand the amount of times that you need to attend the clinic, what appointments are going to occur, what you need to bring to those appointments, how long you're going to be in the clinic for, and what your expectations are when you get to those appointments. I alluded to the consent forms. They're the really important part because they give us your direct instructions about what you want to happen with your gametes, your eggs your sperm and your resulting embryos. After your consultation, you may well have gone away with lots of questions to ask, and this is your opportunity to bring those back to us, and our experienced nurses are well able to answer all of your questions and support you through the next part of your journey. Counselling is a really important part of fertility, and we offer that to you before, during and after your fertility treatment, because it's really important to us that we understand that the stress and everything that goes alongside that rocky road of fertility is supported. So not just us in the clinic, so your nurses and your doctors, your embryologists, all of our admin team are there to support you throughout your whole journey. This gives you an extra layer that if you feel uncomfortable, if you're feeling unsupported in any way, that you can access. So please make use of those. So the next assessment that we need to do when we're thinking about getting you ready for your fertility journey is to make sure that the uterine cavity, if we're going to use yours, is fit for purpose. So we do what we call a saline infusion sonography, so a CIS, where we inject a small amount of saline into the uterine cavity so that we can assess if there's any abnormalities that would not allow an embryo to implant. So if you look at this picture here on the left, the black and white image, this is a uterine cavity, and within that is what we call a polyp. So it's an endometrial polyp that's will not allow an embryo to embed properly. So if we investigate and we find these sort of things, or these anomalies, or we've got any fibroids, any conditions that would hinder your chance, then we would get those removed. A high COSY is when we're thinking about IUI treatment and we want to make sure that your fallopian tubes, because we're relying on the egg to come naturally from your ovaries down your fallopian tubes and meet the sperm. So we need to make sure that those tubes are both open, we call it patent, so that that egg is able to travel nicely to meet the sperm. If we find that you do need any sort of surgery following those investigations, then those can all be arranged, and it can either be via hysteroscopy, which is a catheter introduced through your vagina, or through the abdominal wall called a laparoscopy. So either are very commonly arranged to make sure that we get rid of anything that could cause potential harm or not allow an embryo to embed. So we've done all the investigations, we've had the TIA, and we need to make sure that screening is in place. So this is a mandatory requirement from the HFEA. Anybody that embarks on a licensed treatment therapy through a licensed clinic has screening for HIV, hepatitis B and C, and chlamydia and gonorrhea. That's a requirement for all partners who will be having the fertility treatment. That screening must be done within 3 months of starting treatment, so your egg collection. So if you've had this done already and it's 3 months out of date, we will not be able to accept it. The other thing is, if you do decide to have screening carried out outside of our clinic, that's absolutely fine and your prerogative to do so, but it would be your responsibility to make sure that those screening is carried out at a UCAS accredited laboratory. So when you send us your results, we are unable to accept a display on your phone, a screenshot, etc. We will not be able to accept those. Then the results must come to us on the accredited laboratory's headed paper so that we can make sure that that fits our regulatory requirements. So for the first treatment I'm going to talk about, I'm going to touch on IUI. This is intrauterine insemination. So this is a simple procedure where we pick the healthiest available sperm, whether it's partner sperm or donor sperm, and we introduce it directly into the womb at a given time in the cycle. So we monitor your cycle. We may give you medication to support the follicular growth, so the follicles that hopefully produce the eggs. But we have to be really mindful that if we give you too much medication, you produce too many, then we would have to abort that cycle. So it's about managing your cycle by scanning you and making sure that we don't produce too many. And at a given time, we inject that available sperm, which is washed and prepped, and then we do a test 2 weeks later. So we use IUI in heterosexual couples that maybe don't have direct fertility issues, but could have psychosexual problems such as female vaginismus or male impotence, or even severe premature ejaculation. So those are easy remedies to use, and they're not so invasive as IVF. Single women could access this treatment who are just using donor sperm, so they don't essentially have a fertility issue, they just need the donor sperm. And again, for our same-sex female couples. So it is an option for you. If you feel that you fit into any of those categories, then please do talk to us about it, and we can give you all the statistics around success rates, etc., and what is the most applicable treatment for you. So everything at Herts Essex is about giving you the correct information so you make the informed decisions about your care through Herts Essex. But egg freezing, there's been lots of, we put this slide in because there's been lots of talk, particularly over the last couple of years within the social media platforms. Oh, am I getting too old and should I freeze my eggs? Yes, that's something that we can do at Herts Essex. It's a very easy technique where we carry out the egg collection, but we freeze the eggs in their state that they're coming on that day. So they are stored in liquid nitrogen, and now they can be kept for up to 55 years. Our success rates are really good because of the freezing techniques that we use. So it's a technique called vitrification, and the success rates are 95 to 98% success of those eggs surviving the freeze and thaw status. The quality of eggs obviously are better at a younger age, so the sooner you think about egg freezing. So if you're 34, 35 and you're not in the relationship that you thought you might be in, or you're not ready for parenthood, then it might be wise to think about, should I freeze my eggs for my future? Because the younger the eggs, the higher chance of success that you're going to have. We do egg freezing for all sorts of reasons, so predominantly for social reasons. But it also could be that you're hitting the menopause earlier. You know that your mum hit her menopause quite early, so it may well be something that's affecting you and you've noticed the changes. So it might be wise to think about freezing the stock that you have. Or it could be that you're about to start on cancer treatments and you want to freeze those eggs. And in those circumstances, we can do things very quickly so that we can avoid you stopping or delaying starting treatments for any cancers. The AMH is really important here because it's indicative of your ovarian reserve. So it's really important to know how much your stock is and what you've got there and whether you've got capacity for being able to freeze. In all of this, we make sure that you have counselling so that you're being supported in what you're doing with those gametes, so you can make decisions for your future. I'm just going to give a very quick overview of surrogacy. This is something that Herts Essex is very well known for. We're a centre that has done quite a lot of surrogacy cycles. So surrogacy is when a woman agrees to become pregnant and have a baby for someone else. There's two parties that we generally talk about, but sometimes there can be a third. So we talk about the surrogate, we talk about the intended parents, and potentially talk about a donor. So often it's the only option for women that are unable to carry a baby to term, and it's definitely an option for male same-sex couples. There are two types of surrogacy, one that we refer to as full or host, and that's where a woman carries the intended parent's gametes, so she has nothing genetically linked. Or it could be straight surrogacy where the surrogate, is the egg donor. We've just recently had, for those of you that might be interested in surrogacy, we've spent the last 4 years looking at the Surrogacy Act, which came about in 1985. So as you can imagine, is really not fit for purpose for this day and age and the families that we create today. So the Law Commission just recently has presented its potential reforms to government, and we hope that the changes will be made to make it a much more effective, safe system that we can operate in the UK. But again, if you want to know more about surrogacy, then we do have a dedicated team at Herts Essex, and you can follow up with that tomorrow. So I'm just going to give you a quick snapshot into a typical IVF treatment and what that might mean for you attending the clinic and for you to think about when you're committing to a cycle of treatment. So we've talked about the consultation, we've talked about the screening, we've talked about the treatment information appointment. So now I'm going to talk to you through, once you start on that medication, what happens as you go through. So the drugs that we give you are gonadotrophins. They're powerful hormones that help you develop more than the natural one follicle that you would develop to create that one natural egg. So that's what the body's very clever at doing. You only produce enough hormone to make that one. What we want to do is to try and help you create more than that natural one so that you can create more embryos and therefore have a bigger choice. So if you see this ovary here, remember that ovary I spoke to you about earlier on. So this is a stimulated ovary. So each one of these little tiny antral follicles that we saw at the beginning are now starting to respond to the stimulation drugs that we're giving you. So when we're scanning you at each appointment, we're looking for follicular development, so growth of these follicles. The drugs that we give you generally start on around about day 3 of the cycle, and you'll continue taking those till around about day 14. So we're mimicking or matching what naturally normally happens, and the egg takes about 14 days to mature. As I said, we're encouraging and watching and measuring those follicles as we go along. This treatment continues right through until, as I said, around about 14 days, so 2 days prior to the eggs being collected. As I said, they are powerful hormones. We have lots of side effects. Some people will get everything, some people get nothing at all, but we do need to be mindful that these are common side effects. So headaches, mood swings, breast tenderness, bloating, they're quite common. But when you start or embark on a treatment cycle with us at Herts Essex, that's what we're there for, to support you through. So if you're worried or anxious about some of the symptoms that you're experiencing, then please do talk to us. So at your ultrasound scans, what we're looking for is those follicular developments, but we also want this endometrium. So this is your uterus here, and this nice thickened triple line in the middle is what we call the endometrium. And that's the place where we're going to put the embryo, and we hope that the embryo is going to implant on this endometrial wall and the baby will grow here. So each scan, we're looking for follicular development and endometrial development. But there comes a point where we have to introduce a second drug. So the first drug is stimulating those ovaries, and this second drug, Cetrotide, is the one that will stop you ovulating. You don't want your body to suddenly kick in and start thinking about, okay, I'm going to ovulate all these eggs. And so when we go in for the egg collection, we've got no eggs to find. So it's really important. Every scan, once you've seen the sonographer, whether it's a doctor or a nurse, that scan will be followed up by one of our nurse specialists. So they will make sure that you understand the scan findings and then make sure that you've got enough drugs to get you through to your next appointment. Then it comes to a point that the follicles have grown to a beautiful size and we're ready to think they must be mature now. So we will give you what we call the trigger injection. You'll have seen that on all social media platforms. This is a really important injection that must be given at the exact time that we tell you to give it, because then 36 hours later, when we take you into theatre, we want to make sure that those eggs are going to pop out for us. At every scan appointment, you will get detailed verbal and written instructions to make sure that you understand every point of this. And all of it is backed up on your Salvat so that you make sure that you've got all of the information and that you don't miss the injections. So on the day of egg collection, you're admitted into our recovery bay. You'll have some baseline observations, make sure you're fit and well. If there's a male partner or we're using donor sperm, that sample is provided and prepared, ready to meet the eggs later on that day. We do use sedation here at Herts Essex, so you are put to sleep, but it's not general anaesthetic. So you're only here in the clinic for around about 2 hours. You'll have time to recover once you've had the procedure. We make sure that you leave us in the state that you came into us in. And we have a dedicated theatre team that look after you during your egg collection procedure. So just to really recap, this is where I spoke to you about and thinking about the commitment that you have to make, how many times you need to attend the clinic. So you start your period, around about 3 days later, you start taking the first lot of injections, and you'll take those for approximately 14 days. You'll have 1 scan, 2 scan, maybe 3 scans. It all depends on how you respond to that medication. And remember, around about day 5, we're going to introduce that second injection, which is Cetrotide, and that's the one that's going to stop you ovulating. And so from around about day 5 or 6, you're taking 2 injections every day. We get to the trigger point, we trigger those ovaries to make sure that those follicles are going to release the eggs for us. 36 hours later, you come in for the egg retrieval, and that's where we put you to sleep and we take the eggs out. Then you start the second lot of drugs, which is the progesterone. So these are all estrogen based, following and mimicking the egg growing. Now we want to support an embryo implanting, and so we give you progesterone, and that can be in the form of pessaries and potentially an injection as well. So egg recovery is day 0, and embryo transfer is most likely to be day 5. There is the potential it could be day 3 if you only have 1 or 2 embryos, but potentially day 5. And from egg recovery until you do a pregnancy test is 2 weeks, 2 weeks and 2 days. So from here, the beginning of your period, right through to here is approximately 4 weeks. So that gives you some sort of indication of the amount of times that you're going to attend the clinic and the commitment that you need to make when you embark on your treatment pathway. So really make sure that you're in the best place to do that. Don't think about, you know, that, well, I'm going away for a long weekend or I've got a stag weekend in the middle of it. It's just not going to work. You need to make sure that you commit to this cycle, you make yourself free, and that you're in the best physical and mental state to do so. So I'm just going to talk a little bit about the gametes, I keep referring to, so your eggs and your sperm, and then your resulting embryo. So how do we get to that point? We know that we're going to collect the eggs, we know that we collect the sperm, and then we need to collect the embryo. And we do that in a couple of ways. So IVF is in vitro fertilisation. In vitro just means outside the body. So we're creating that embryo with your eggs and with your sperm, but outside of the normal reproductive system. Intracytoplasmic sperm injection is ICSI, and that's where we bypass the normal IVF procedure where we just let the eggs and the sperm do their own thing, where we individually put a sperm straight into an egg, and I'll show you some video footage, etc. on that. PICSI is where we take ICSI to the next stage, where we're drilling down into the actual physiological state of that sperm. So we really look at when we're picking that best sperm. And again, I'll give you some indicators as to which ones we use. So IVF is when we've got, it's all around the sperm, is when we've got normal sperm parameters. So the latest WHO, World Health Organization, determines that a normal sperm parameters are 20 million sperm per milliliter of ejaculation. So if your parameters fall below that, then we know that we might have to think about considering ICSI. Out of those sperm parameters, at least 50% of those sperms need to be motile. So they need to be swimming in the right direction, not twiddling around on their heads or swimming backwards. They need to be going in the right direction. When you produce a sperm sample, 85% of that sperm will be abnormal. So we need 15% to be really good. And out of that 15%, we want a good quantity of good sperm. So HBA is high hyaluronic binding assay. So if you look at this picture here, this is an egg and the sperm are binding to that egg. So there is a component that the sperm are attracted to, so that assay, and that's what drives the sperm to the egg. So we want that score to be more than 65%. And if it's less than that, then we know that we might possibly need PICSI. So when do we use ICSI? So I alluded to that. If any of the parameters, so the count or the motility, or we've got abnormal sperm, are showing up in your semen analysis, then we will consider using ICSI. And that's where we directly put a single sperm into the egg. If we've got no sperm in the ejaculate and we need to surgically remove the sperm from either the epididymis or the testes, we would automatically use ICSI for those, because we know that that sperm is not going to be as strong. If the sperm has is MAR positive, which means that it has anti-sperm antibodies, so rather than a sperm swimming around doing its own thing, it'll clump together and will be ineffective. So if you've got a MAR positive sample, we would use ICSI so that we can separate the sperm and use an individual sperm. If you've known that you've had previous failure to fertilise or low fertilisation, we might again consider using ICSI to help override that natural fertilisation process. So just to give you some indicator, this little video here. So this pipette here is finer than a human hair. And what the embryologist is looking for is a sperm that's swimming, going in the right direction, morphologically looks good. So it's got a nice head, it's got the right length of tail, it looks like it's doing the right thing. So they examine the sample, make sure they find that sperm. So they've indicated that they found a sperm. First thing they do is crack the tail of the sperm, because we don't want to put the sperm in and then it swims out. So it looks barbaric, but it's not. You can see it's just a crease in the end of the sperm there. They suck the sperm into the pipette, and they take that pipette then over to the holding device. So this holding pipette here has got the egg. You can see it looks like it's got a load of cumular cells. So that's the structure that supports the egg around the outside. So the embryologist now, can you see the sperm here, is going to inject that pipette directly. It looks like it's popping a balloon. Again, it looks a bit barbaric, but it's not. So they suck up a little bit of the cytoplasm from the inside of the egg, mix it, so they're introducing the egg and the sperm together already, mix it with the sperm, and then you can see they've deposited that sperm. So if you've got 20 eggs, we will need to do that 20 times with each individual egg. And then those eggs are put back in the Petri dish and put into the incubator, and hopefully we see fertilization tomorrow. So PIXI, as I said, I talked about HbA, high hyaluronic binding assay. So we know that sperm are attracted to the HbA around the surface of the egg. So what we do to determine, when we do our routine semen analysis, we're probably one of the only clinics that do it as a routine, so there's no extra cost to you. So we put HbA into a Petri dish, we'll put the sample in there, and if we see that the sperm is going directly to that HbA points, then we know that they're the strongest sperm that are able to get there. All the others that are pushing to one side. So when you look down a microscope and you see a sperm, they can look morphologically the same. So they've both got nice heads, they've both got the same length of tails and their body, etc. But one could be mature and one could be immature. And you won't directly know that without testing the HbA. And if you inject an immature sperm into an egg, it may well give rise to a pregnancy, but it's more likely to cause problems. So miscarriages, it's very common. So we want to avoid that happening. So if you've got a low HbA score, we will always recommend PIXI for you. So just to give you an indication of what an embryo looks like. So what I said to you, egg collection day is day 0. The following day, whatever means we've created with IVF, ICSI or PIXI, we want to see this same structure. So this is the egg that's had the sperm inseminated, and then we have these two structures in the middle. They're called two pronuclei, one from the egg, one from the sperm. This is a normally fertilized egg. So this is a good thing. So you'll get the call from the embryologist the next day. Say you had 10 eggs, you've got 8 that are fertilized beautifully. We take it to the next day, 2 days later, sorry, we don't look at them on day 2. And on day 3, we want to see those two pronuclei starting to divide. So by day 3, we want to either have 6, 7 or 8 cells, roughly around that area. So they're multiplying by 2 every day. So these are two beautifully, a 6-cell and an 8-cell embryo that are looking exactly as they should be on this day. We then don't look at them at day 4, and we come to them on day 5. And this is the most likely day that you would have an embryo transfer. So you can see it's a very different looking fertilized egg. So this is that same egg that's now, those cells are now divided into over 100 cells, and they separate into 2 distinct groups. So this area here at 11 o'clock, that's called the inner cell mass, and that's a group of cells that are clumped together, and that will give rise to the fetus. And the cells sitting around the circumference of this egg here are what they call the trophectoderm cells, and these are the cells that will give rise to the placenta and support the baby. And if you look here around about 3 o'clock, you can see that this blastocyst here, or blastomere, is trying to hatch out of this shell. So that's a really good looking blastocyst that's already thinking about implantation. We will look at those on day 6, and if we certainly transferred on day 5 and you've still got embryos left, but they're not quite at the right stage, we will leave them until day 6 and follow them on the next day. So you can see that this is a blastomere trying to hatch out of the shells. It looks like a peanut. And then on the right-hand side, we've got a fully hatched blastocyst. So this is an embryo that now is capable of implanting on the endometrium. So the shell gets left behind and you've got this beautiful expanded blastocyst. So on the day of embryo transfer, so we know we've got that beautiful embryo. We've picked the one that we believe has got the best chance of success, and we show you that embryo. So you'll see that on the picture before you have that embryo implanted. So it all depends on how many eggs you've got and how many you want to be transferred. But we really encourage elective single embryo transfer because we don't want to be misrepresenting you and allowing you to have multiple pregnancies. So our embryo transfers take place 7 days a week, and that's really important when you're thinking about the clinic you want to choose, because you want to make sure that you're going to maximise your pregnancy chance and not just because the clinic can't open on a Saturday or a Sunday. So when your embryos are ready, then that's the day that you'll have your embryo transferred. As I said, you get to see the embryo before you go, and we give you a picture of that, so something for the scrapbook. We do offer embryo glue here at Herts Essex, but it is an extra add-on, and this purely is a media that mimics the uterus, so it helps the embryo get used to the state. So a bit like when you introduce the egg and the sperm together and you mix the cytoplasm, you're doing the same here. So it just mimics the condition of the female uterus and introduces the embryos about an hour before they're inseminated into you. So again, you can talk to us through that when you start with us, and we give you all that information at the beginning. We do pre-implantation genetic testing here at Herts Essex. So it might be that you've had failed treatments in the past and you want to determine whether your embryos that you're putting back have got the correct amount of chromosomes, so the 23 pairs, male and female. This is called PGT-A, which is aneuploid. So you want to determine whether this is the best embryo that can go back. If you want to look at a certain disorder, so if you know that you've got an inheritable condition, you want to rule out passing that genetic condition on, then you can have PGT-M. And then if you want to look at the next stages, so the structural rearrangements, we call it, so you're screening for various different chromosomes that you might not know that you genetically have, but you're trying to screen out anything that has got the potential to cause harm to your fetus. So that is something extra that's added on. And again, when you come to the clinic, if that's something that you're more interested in, then we can give you all of the information around that too. We're very proud to say that at Herts Essex, we are the clinic that invented IVF Witness alongside a very clever embryologist that was here with us. So this rules out chances of mixing up in the lab, etc. So you have reassurance that when your embryos, your eggs and your sperm are in our care, that they are tagged to you. So this is an electronic witnessing tagging system that ensures that every time your gametes are brought out into the laboratory, that they are yours. So you'll be given the card, you'll see exactly what your embryos are, and you can see that they're tagged to you. So it gives you reassurance that when your gametes are in our care, that they're being well cared for. So hopefully we've had the egg collection, we've put the embryo back, and now we're hopefully coming in for a pregnancy test. We offer 2 early scans. So it's compulsory that you attend the clinic for the very first scan at 7 weeks, because we have to give that information back to the HFEA. That's a requirement and mandatory that we provide them with that information. So this scan here on the left, the black and white image, is typically a 7-week scan, or it's just under. And what we're looking for is that we've got a viable pregnancy. So that's a pregnancy that's in the right place. How many? Whether we've got all the parameters that we need within that, and then the viability is the heartbeat. So this is a beautiful looking fetal pole with a yolk sac sitting in the right place within the uterus. We then can bring you back at 10 weeks, and we're seeing a very different picture here, because at that point you can very clearly determine head, body, arms and legs, and lots of movement, pumping heartbeat. But we can also do the non-invasive prenatal test here. So that's a blood test with a scan that looks at some of the more common chromosomal abnormalities such as Down syndrome, Edwards syndrome, and Patau's. So those are conditions that cause life-threatening conditions to your baby, but also threatened miscarriages, etc. So if that's something that you've had in the past and you wanted to investigate further, then you can. So we all know that it's very costly experience to come down the fertility pathway through a private fertility clinic, but we do have NHS funding here at Herts and Essex, so there are other ways. So you need to determine through your GP or your local NHS whether you are entitled to funding. And if you're unsure about any of that and you want to ask, then just give us a call and we can tell you whether we can support you through our NHS contracts, whether we can support that. So these are just some of the NHS contracts that we can include at Herts and Essex. And again, you go through your GP or your gynecology referrer and they can refer you directly to us. We also have North Central London, which covers these areas. If NHS is not applicable to you and you're in a position to think about whether you would share your eggs or your sperm, then we do have funded treatment pathways that can support you through that. So typically our programs include egg sharing, sperm sharing, or if you want to think about freezing your eggs, but you would, to help you meet the cost of that, that you would share half of that cohort of eggs in that cycle. Again, if you think you're in a position to do that, we can talk to you further around it, and we've got a dedicated team that can give you lots of information about what that might entail. So just to give, I can't give you the whole realms of treatment costs, but we're very transparent. If you go onto our website, you can see a whole list of all of our costs, but sometimes it can be quite mind-blowing because you have no idea what physically you need to have carried out. So this is just to give you some indication. So a typical IUI treatment costs 1,150, as opposed to IVF 3,800, ICSI 5,000, and so on, going on. But all of these do not include screening or medication. So you need to allow, depending on the cycle of treatment that you're having, the amount of medication that you're going to need. So again, talk to us around your treatment pathway and we can help you really look into that. We do partner with Access Fertility, and this is a group that funds fertility treatment. We are a clinic that they access, so you go directly to them, but we can give you all the information on here, and they have various different fertility packages that includes fully funded refunded treatment cycles. So it means that after a certain amount of treatment cycles, you pay an upfront cost, but if you don't get the baby at the end of it, you get a full refund. So these are really well worth looking into. These are a really approachable company that will help you look into whether you are applicable to apply. And lots more information on there. We do have all of this. We do have links on our website directly to Access Fertility also. So please do have a look at them if you're thinking about funding or worrying about funding. So wellness at Herts and Essex is really important to us. We understand fully that this is a rocky road of a journey for most of you embarking on it. We want to make sure that you know that you're supported throughout your cycle with us, not just from the nurses and the doctors and the embryologists, but to make sure that you have areas where you can go to if you're seeking advice outside of the clinic that is safe and effective and giving you the right advice. So look at our particular platforms, our Facebook, our Instagram, our Twitter feeds, and join those platforms so that you can get support from each other. Invariably, you might be sitting at home thinking, oh my goodness, is this really happening to me, and should I be experiencing this? And when you start to talk to people that have experienced exactly the same as you, you've automatically got a nice support network. So do use those platforms. They are monitored by our staff here, so we make sure that any information that's on there is correct and valid and up to date. I started right at the beginning saying that you need to be in the best physical state, and that includes your diet. So if you're either overweight or underweight, think about correcting your diet to get yourself into that best physical shape. So we do partner with a dietitian who really does focus in on fertility diets completely. She gives one-to-one advice. She writes lots about nutrition and what's the best types of foods. There's no wacky things, you know, eat 2 tins of pineapple a day, whatever it is, all those wacky things that we get told about. She writes lots of blogs that are fertility focused. So some really interesting advice on just how to get yourself into that best physical state. So just to sum up a little bit about us, so we've had 34 years of experience purely in fertility, just. We run a 7-day-a-week laboratory service. That's really important when you're considering embarking on a fertility journey. We do have that safeguarding of our electronic witnessing system, our tagging system that protects your embryos, gametes when they're with us. 7,000 babies, that tells you that, you know, we are a successful clinic that supports you throughout your journey with us. But most importantly, we want you to have that take-home baby. The support throughout your treatment, as I said, not just from the staff here with so many years of experience, but also through the networks that we provide you with. It's really important that you have that emotional support, and that's both of you, whoever's within the partnership, to make sure that you're both feeling included and that you have the right support to help you get through this rocky road. So I hope that's given you a little bit of an insight into Herts and Essex. It's very difficult in the short time that we have together to get across every treatment pathway, but we're here answering your questions. If you've got anything specific you need to ask us, then please do pop on there and show us. Just to let you know that we really do value your feedback. It's really important that when we send you that feedback short survey form tomorrow, that you do connect with us and let us know if there's things that are missing from this presentation that perhaps you might like to have known. Timing is a really important one, so I'd really appreciate if you could just say something around whether it's appropriate that 6 o'clock was a good one, or are you rushing in from work and you haven't had time for your tea, all of that. Just let us know. If you want to know more about Herts and Essex, just do connect with us. Go onto our social media channels. You'll see lots of input on there, lots of blogs, lots of information, patient stories, patient babies, all of those sorts of things that help you engage with the clinic. If you wanted to book an appointment with us, you know, the numbers are there, but again, on the when we feed back to you tomorrow, you'll see all of that information again. And just to give you an indication, an appointment with us at Herts and Essex for a couple is approximately £400, and that includes your AMH test, your thyroid function test, and any semen assessments that need doing. And at the moment, we're booking consultations of 4 to 6 weeks roughly. So please do give us a call if you're interested in thinking about starting your journey, and I'm sure that we can help you. So I'm going to just try and pop onto this video now and see if we can get you hooked into that. Give me a sec. Oops, no. Have I connected, Mama? 1 second. Just get you booked back on. Oops. That's where I'm going there. Stop sharing. So. I did just share it. Excuse me, guys, let me just get you back onto this. Okay, thank you very much for attending this evening. I hope that you've learned a little bit of information around what Herts and Essex can offer you. Please do answer all your, ask us all any questions that you still have outstanding. We'll endeavour to get those answered. We'll stay on for a few more minutes. Thank you very much for attending.